All right, today we're diving into one of the most frightening emergencies in all of gastroenterology, acute variceal hemorrhage. This is a true high-stakes life or death situation, and every clinician really needs to know the playbook. So we're going to break down exactly what's happening and what we need to do step by step.
So, to really set the stage, let me just ask you a question. When you think about a patient with advanced liver disease, with cirrhosis, what do you think is its single deadliest complication? It's not the confusion from encephalopathy, it's not the fluid buildup from ascites, it's bleeding. And this is what we're talking about. This isn't some minor bleed. We're talking about a catastrophic rupture of these swollen, fragile blood vessels inside the GI tract. This is acute variceal hemorrhage, or AVH, and it demands immediate, perfectly coordinated action. So here's our plan for today. First, we'll get a handle on the crisis itself. Then, we'll dig into the liver's underlying plumbing problem. After that, we'll cover how we actually find and confirm the leak, the absolute race against time to stop the bleed, and finally, how we prevent it from ever happening again. Okay, so to really get a grip on this emergency, we have to start at the very beginning, with the root cause. The best way to think about it is that the liver has this incredibly complex plumbing system, and when cirrhosis hits, that whole system gets horribly backed up. And the name for that backup is portal hypertension. I want you to imagine a massive traffic jam on a superhighway. In cirrhosis, all that scar tissue in the liver acts like a giant roadblock for blood trying to get through the portal vein. So blood backs up, and the pressure inside that system just skyrockets. Let's trace how that happens, step by step. First, you get that scarring in the liver that blocks the normal flow of blood. Second, the pressure inside that portal vein builds and builds to really dangerous levels. So, what does the body do? It tries to find a way around the traffic jam. It forces all that high-pressure blood into these small, fragile detour vessels. And those swollen detours, well, those are what we call varices. They usually pop up in the esophagus and the stomach, where they are just incredibly vulnerable to rupture. But here's the thing. Not all varices are the same. Where they're located is absolutely critical for how we treat them. This diagram here shows the Sarin classification. You can think of it as a super-specific anatomical map, just for the varices in the stomach. Knowing this map tells us exactly what our game plan needs to be. And this chart breaks down those types. Now, GOV1, those are the most common. They're basically just extensions of varices coming down from the esophagus. But the ones you really have to watch out for are GOV2 and IgV1. Why? Because they're up in the fundus, the very top of the stomach, which means they're often bigger and much harder to treat with the usual methods. Making this distinction is absolutely key. So let's just boil this all down. The crucial takeaway is this. AVH is a bleed from a rupture. That rupture happens because of varices, and those varices form because of that intense back pressure from portal hypertension. And if you're going to remember one number, remember this. Once that pressure gradient gets above 12 millimeters of mercury, the risk of a bleed just goes through the roof. Okay, so we've got the why down. Now let's shift gears and focus on the what. What does this actually look like when a patient rolls into the emergency room? How do they present, and how do we prove definitively that it's a variceal bleed? The presentation can be incredibly dramatic and, frankly, terrifying. Patients might be vomiting large amounts of bright red blood. That's what we call hematemesis. Or they might have these black, tarry stools called melena, which is just digested blood. And critically, they often show signs of going into hemorrhagic shock. Their heart is racing, their blood pressure is plummeting, they might be confused. All this is often happening on top of the classic signs of cirrhosis, like yellow skin or a swollen belly. Now, we might have a really strong suspicion based on all those signs, but the gold standard, the one test that gives us the definitive answer, is an EGD, or an upper endoscopy. The guidelines are crystal clear. This procedure needs to happen within 12 hours of presentation, as soon as the patient is stable enough. It's our tool for both diagnosis and treatment. And this gives you a window into what the gastroenterologist is seeing. On the left, a normal, healthy esophagus. On the right, you can see those huge, twisted, bluish vessels just bulging into the esophagus. It's pretty obvious how easily something like that could rupture under pressure.
During that endoscopy, we're looking for proof. The most obvious, of course, is seeing active, spurting bleeding. That's the smoking gun right there. But even if the bleeding is stopped for a moment, we look for other clues. We might see a white nipple sign, which is just a little fibrin plug telling us, hey, this is the spot that just ruptured. Or we'll look for red whale marks. These are signs that the wall of the varix is stretched super thin and is at a very high risk of bleeding again, soon.
So let's recap the diagnosis. The bottom line is this. If a patient with known cirrhosis comes in with a GI bleed, you must assume it's variceal until you prove otherwise. The clinical picture is usually pretty dramatic, and the definitive next move is to get that endoscope down there to see what's going on and hopefully start fixing it right away. All right, now for the main event. We found the leak. The clock is absolutely ticking. This next part is all about the urgent, simultaneous steps we have to take to save this patient's life. First things first, resuscitate. We go right back to the ABCs. We have to protect the airway, especially if the patient is confused or actively vomiting blood. We need to get at least 2 large bore IVs in for fluids and blood. And here is a super critical point. We use a restrictive transfusion strategy. Now that feels completely counterintuitive, right? But overtransfusing can actually raise that portal pressure and make the bleeding even worse. So we aim for a hemoglobin of 7 to 8 and no higher. At the exact same time we're resuscitating, we're medicating. There are 2 classes of drugs here that are totally non-negotiable. First, vasoactive drugs, like octreotide. We start these immediately, even before the EGD. They work by clamping down on blood vessels that supply the gut, which helps lower the portal pressure and slow down the bleeding. Second, we give prophylactic antibiotics. Why? Well, it turns out bacterial infections are a major trigger for bleeding in these patients, so preventing one is absolutely key. Now, this slide is pure gold. These are the high-yield clinical pearls. We've talked about what to do. Now let's talk about a classic mistake, what not to do. Do not give fresh frozen plasma just to correct a high INR. In cirrhosis, the INR is not a reliable marker of bleeding risk. The liver isn't making clotting factors, but it's also not making anti-clotting factors. So giving FFP just adds volume, which makes the portal hypertension worse. And also, avoid things like recombinant factor 7A. They just haven't been shown to help and might even cause harm. Okay, with the patient stabilized, it's time to intervene directly on the bleed. The workhorse for esophageal varices is something called endoscopic variceal ligation, or banding. It's basically like putting a tiny rubber band on the varix to choke it off. For those trickier gastric varices, we often use a special injectable cyanoacrylate glue. It's like medical superglue to plug the vessel from the inside. And for the absolute worst uncontrolled bleeds, we bring out the big guns, a TIPS procedure, where a shunt is created inside the liver to literally reroute blood flow and dramatically lower the pressure. So the main takeaway from management is that it's a 3-pronged, simultaneous attack. You resuscitate, you medicate, and you intervene, all at once. Just remember those core principles: transfuse restrictively, get the vasoactive drugs and antibiotics on board early, and then get to endoscopy for the definitive fix. Okay. The immediate danger is over. The patient has survived the acute bleed, but our job is far from done. The underlying problem, that portal hypertension, is still there. So now our entire focus shifts to preventing the next, potentially fatal rupture. This table shows the really important difference between primary and secondary prevention. See, before a patient has ever had a bleed, we might just use beta blockers or do banding. But once a patient has bled, the game totally changes. The standard of care is aggressive combination therapy. That means lifelong beta blockers to keep the pressure down, and we bring them back for serial banding sessions to systematically get rid of every single varix we can find. And that really brings us to our final thought. Controlling the bleed is just winning one battle. The war against portal hypertension and the cirrhosis that's causing it, well, that's ongoing. And this whole experience just highlights how critical it is to manage the root cause, the liver disease itself, to prevent not just another bleed, but all the other devastating complications that come with cirrhosis.